Dr. Surya Nalita.
Good evening, ma'am.
Yeah, are you here? Okay.
Yes, ma'am. Yes, ma'am. Good evening, ma'am.
Okay.
Ma'am, we are live now, ma'am.
Good evening and very warm welcome to the TNFOG BODHANA case discussion for the PGs. The topic today is heart disease complicating pregnancy. I thank Dr. Vidya Prabhakar ma'am, Dr. Sampath ma'am, Dr. Anjalakshi ma'am for involving me as a MOC in this program. And it is a interesting PG case discussion. And I request invite Dr. Anjalakshi ma'am, who is the founder president TNFOG, past president of OGSI and past president of DIPSI. She's done PhD in pregnancy in diabetology from the Tamil Nadu Dr. MGR University and recipient of the Best Doctor Award from IMA. She's a retired professor from Madras Medical College and presented a number of papers of national international conferences. And she's done great research work in GDM, diagnostic testing, and OHS in GDM. Lifetime Achievement Award in DIPSI in 2022. Welcome, ma'am. And we welcome Dr. Vidya, ma'am, President TNFOG 2025 to 26. And she has been the past president of OG Society of Salem.
Yeah, that's enough, Dr. Radhika.
Welcome, ma'am.
Very nice.
So we would like, we requested Dr. Vidya, ma'am, to bless us with a few words, ma'am.
Yeah, good evening and thank you, Dr. Radhika. And good evening, Anjalakshi ma'am. I think she's there. Dr. Sampath ma'am, I don't know whether she's joined or not as yet. And Dr. Aruna Suman, she's a wonderful teacher. So I'm happy to see her as an external here and all the other wonderful internals as well as external teachers and presenters today. Actually, these BODHANA programs actually give me a lot of interest and I feel very young when I watch that because you go back to those days when you were grilled by your seniors. And then as seniors, we were also grilling others. So, I mean, it all goes back to those times. And it's very nice that we are discussing heart disease with pregnancy. Many times nowadays in conferences, we are not able to cover these kind of topics because these we feel are, textbook topics like PG topics and all that. I hope there is something interesting coming up in this particular case presentation. And I hope and all the PGs who are attending will become very clear as to how to present a heart disease case in pregnancy and face the viva as well, because the externals today are going to be really charged. And so I'm waiting to hear all that. Thank you very much.
Thank you, ma'am. Thank you, Vidya, ma'am. So I take great pleasure in inviting Dr. Nagasudha, ma'am, who is associate professor from Government Sivagangai Medical College. She's completed her post-graduation in Stanley Medical College. She's has been working in Aishwarya Fertility Center, and she got the Best Doctor Award in 2020 to 21. And she's presented a paper in reputed journals, and she has 11 years of teaching experience for the undergraduates and postgraduates. Sayati, okay. Then we have Dr. K. Tenarsi, who is Associate Professor from the Government Sivagangai Medical College, UG and PG teacher for 13 years. And she is a master trainer for EMOC and a field of interest is high-risk pregnancies and published many papers in national and international journals. And we have Dr. Priya Darshini, who's doing dependent BOG from Madurai Medical College, and she's done the PG from Government Virudhunagar Medical College, and she's also a member of International Society of Ultrasound in OBG. She's presented papers on CS cervix in ASCOG. Her field of interest is advanced laparoscopic surgeries and infertility. Our main external is Dr. Aruna Suman ma'am, who's a very great speaker, and she's a professor of OBG, HOD from Medical College, Jagtial, Telangana, and she's has been the joint secretary in FOGSI 2021, and she's been the organizing secretary in ASCOG Hyderabad 2024. And
thank you, Dr. Radhika. Thank you so much.
Thank you, ma'am. She's got many awards. Welcome, ma'am. And we know Dr. C. Suhasini Karnal, who is a consultant obstetrician gynecologist and a laparoscopic surgeon, was done her UG in Chengalpattu Medical College and PG in CSI Rainey Hospital. and she works as Associate Professor in Sri Muthukumaran Medical College. She's a life member of COGS, FOGSI, and IMA Tambram, and she's been a faculty in state and national conference. Also, she's contributed a chapter in Handbook on Labor Management. Welcome. Welcome all the internal examiners and external examiners, and good luck to our students. Dr. N. Navanida, final year PG, Sivaganga Medical College, and
Thank you, ma'am.
and Dr. Surya, final year PG, Sivaganga Medical College.
Thank
We can start the presentation.
you. Yes.
Share your slides, please.
Hello.
And we see a lot of heart disease complicating pregnancies. Actually, in last 3 months, I think 3 women had died of in our district. 3 women had died of heart disease, the mitral stenosis. Some of them are unaware. Dr. Surya,
Yes, ma'am.
so it's very important that we all know
Yes,
about the
ma'am.
management.
Please make it as full screen, ma.
Yes, ma'am.
Surya, ma'am.
Yes, ma'am. Yes, ma'am. Opening.
Actually, we have a lot of cardiac disease complicating pregnancy, madam. But since the want of time, we are going to discuss only 2 cases.
Okay.
I think with these 2 cases, we will have a broad idea about one is rheumatic and the other is congenital. That is
Congenital,
how
very
we are
good.
taken. Even though we have a lot of severe MS, orphans, but we cannot post all the cases
Yeah,
here.
yes,
So we have
absolutely.
taken 2 simple cases and they are going
We
to
should
prove.
have a broad view of the management,
Yes,
especially in the acute setting when they come with, sometimes they present as
can
demand.
discuss. Sure, madam. Sure, madam.
I'll understand. Is my screen visible, ma'am?
No, da, it's not visible.
No, Surya, we are not able to see your screen.
Once again. Once again.
Stop share and reshare it
Previously, it was
again.
visible. Previously, it was visible.
Thank you.
Now
Is
it
it
is
visible?
post for the screen slideshow. Da.
Slideshow, yes.
Is visible, ma'am?
Yes, yes, ma'am.
Start presenting, ma.
Can I start, ma'am?
Yeah, you can start.
A very good evening, ma'am. Myself, Dr. Namita, final year postgraduate of Government Sivaganga Medical College, here to present a case scenario on heart disease complicating pregnancy. My case, Mrs. X, wife of Mr. Y, 19 years old, prima gravida, residing at Manamadurai, who's a housewife by occupation, studied up to 5th standard, belonging to lower socioeconomic class according to the modified Kuppaswamy scale. She was a booked and immunized case at Manamadurai GH with her last menstrual periods on September 18, 2024, with her expected date of delivery on 25th of June 2025, with a gestation age of 39 weeks, has been referred from Manamadurai GH as a case of heart disease complicating pregnancy for safe confinement. The patient is able to perceive fetal movements well, and she had been admitted for safe confinement. History of presenting illness, history of amenorrhea for the past 9 months. She had complaints of swelling of both legs for the past 1 week, which is insidious in onset, aggravated at the end of the day, which is relieved after rest. There is no history of headache or vomiting or blurring of vision or decreased urine output or epigastric pain. And there is no history of difficulty in breathing or history of orthopnea or paroxysmal nocturnal dyspnea. And there is no history of palpitation or chest pain or syncopal attacks. No history of cough with expectoration or hemoptysis. There is no history of childhood fever associated with joint pain or swellings. There is no history of recurrent episodes of sore throat in childhood. There is no history of lower abdominal pain or draining or bleeding feeling. Menstrual history, the patient attained menarche at 12 years of age. She had regular cycles, 5 days, once in 30-day cycle, and she changes 2 to 3 pads per day. There were no history of dysmenorrhea or passage of heavy clothes. Marital history, the patient married since 1 year, and it was a non-consanguineous marriage. Obstetric history, first trimester, she had spontaneous conception and she conceived within 1 year of marriage. Urine pregnancy test was positive at 45 days of amenorrhea and the pregnancy was confirmed by dating scan. History of folic acid intake was there. There was no history of excessive vomiting or fever with rashes or urinary tract infections or spotting or bleeding feeling. There was no history of exposure to radiation or drugs. Nuchal thickness scan was done at 11 weeks and was found to be normal. Number of antenatal visits in the first trimester were 2. Second trimester, quickening felt at 20 weeks of gestation. History of iron and calcium tablet intake was there. Anomaly scan was done and was found to be normal. Fetal echo staining was done at 18 weeks and was normal. Glucose challenge strength was done at 14 and 24 weeks and values were within normal limits. Number of antenatal visits in the second trimester were 4. Third trimester, the patient continued to perceive fetal movements and there was no complaints of bleeding or draining or lower abdominal pain. Streaming echo was done at 32 weeks, which showed congenital heart disease of atrial septal defect. Austin secundum type with 10 millimeter defect with left to right shunt, and there was no pulmonary artery hypertension. Minimal right atrial and right ventricular enlargement was there, and ejection fraction was 64%. Cardiologist opinion was obtained, who told it was a low risk cardiac chase and advised for postnatal follow-up.
Surya, I would like to.
Ma'am, myself, Dr. Namanita, ma'am. Ma'am, am I audible, ma'am?
Why did you take the history of socio-economic status and how is it related to your case? Is it important to take the history or elicit the history of socio-economic status, and how do you divide it?
Yes, ma'am. As it is a rural population, I take into account the modified Kuppasamy scale into account, ma'am. Depending upon the education, income, and occupation of the patients are being classified into upper class, upper middle, upper lower, and lower class, ma'am.
So you're talking about the modified Kuppasamy classification, is that right?
Yes, ma'am.
How is it related to your case? Is it important?
Yes, ma'am. It's because low poverty and lower socioeconomic class, there's increased incidence of rheumatic fever in those people, ma'am, which can precipitate rheumatic heart disease in future in those pregnancies, ma'am. Okay. As it was a heart disease complicating pregnancy, I elicited those histories, ma'am.
Okay, right. Is there a relation to congenital heart disease in that group of socio-economic status?
Yes, ma'am, to some extent, ma'am. It's because if the patient belonging to a upper socioeconomic class, minimal symptoms could have provoked the patient to go and seek medical history and should have been found this earlier, ma'am. This could have been diagnosed earlier. Because of the poverty or lower socioeconomic class, the diagnosis would have been delayed in this patient.
Okay, Navnita, is it a booked case or an unbooked case?
She was a booked case, ma'am.
So what do you mean by booked case? I want the exact definition of booked case.
Yes, ma'am. A booked case should have at least 4 antenatal visits throughout the entire pregnancy and should have taken 2 doses of injection TD and 100 days of iron and folic acid supplementation.
And I would like you to add one more important point. So she has got all 4 visits in the first and second trimester. Would that suffice?
No, ma'am. The patient should have at least 1 visit in the first trimester within 12 weeks of gestation.
Okay.
And the other 2 visits in the second trimester and the final 2 visits in the third trimester of the pregnancy, 1 nearing term, ma'am.
Nearing term, that means within 1 month of her EDD. That is also important. Okay.
Yes,
that will minimize many complications because of heart disease or any other medical disorders in pregnancy. Okay. Okay, continue.
Shall I continue?
Okay, about let me see your symptoms, please.
Patient as such have
I mean the complaints. No, complaints. Let me see your
swelling of legs for the past 1 week, ma'am.
So what type of edema is it, and what is the significance of edema?
Yes, ma'am. Actually, the patient is having the complaint for 1 week and it is insidious in onset. It is aggravated at the end of the day and it is being relieved by rest, ma'am. So it is mostly indicative of physiological edema.
So 40% of the pregnant women will have edema. So you have to differentiate between physiological edema and pathological edema. So what is the difference? How do you exclude that it is not a pathological edema? One point you said is it is relieved after rest. Yes.
Yes, ma'am.
One point. And the other points?
Other point is it will be mostly in the dependent portion of the body, ma'am, like ankle and feet, ma'am.
Okay.
And also it will not be associated with other symptoms like decreased urine output or other symptoms of failure or preeclampsia, ma'am.
Okay, so with pathological edema is present elsewhere on the fingers, face, and there can be anasarca. Okay, there can be ascites also, depending on the grades of the edema. And which doesn't relieve on rest.
Yes, ma'am.
Okay.
Shall I proceed, ma'am?
Yes.
What is the Navanita? What is the significance of this history of preeclampsia in this patient?
Hypertension can be a precipitating factor for cardiac failure, ma'am.
Very good. So what are the other things? What are the other things that can precipitate failure in this patient? apart from hypertension.
Yes, ma'am. Anemia, associated infections like urinary tract infections, uncorrected hyperthyroidism, and also pain and increased anxiety can precipitate heart failure, cardiac failure in this patient.
So preeclampsia, hyperthyroidism, infection, anemia, and your pain, labor pain can precipitate
Yes,
failure. Apart from that,
yes,
you can have previous history of any cardiac event. If it is positive, that is also going to precipitate your failure.
Failure.
So if the
yes,
patient history of failure in previous pregnancy, this pregnancy
yes,
is also before pregnancy. And you have told that this patient is aged 19 years.
yes, ma'am.
So she is a teenage pregnancy. What is the
Yes, ma'am.
significance of this age? If the patient has come to you prior to her marriage, that is for preconceptional counseling, what would you have given? What would be
Yes,
your
ma'am.
advice?
Yes, ma'am. The patient is at 19 years of age, ma'am. As it is a teenage pregnancy, those patients are more prone for anemia, infections, as they are malnourished, underweight. The risk also carries to the baby like preterm labor, prematurity, low birth weight. Those can be there, ma'am. If the patient comes to us before pregnancy or before marriage, preconceptional counseling can be advised in those patients, ma'am. First, the evaluation of the cardiac disease should be done thoroughly, ma'am, to decide the nature of the cardiac disease. And next, we have to classify the functional status of the heart disease, ma'am. And we should advise the patient for optimum time of her being married and also for to become pregnant, ma'am. This patient, as she's a case of atrial septal defect, she could have been diagnosed before. She's having a significant lesion of 10 millimeter size, ma'am. So we could have got a cardiologist opinion and sought for some device closure before she become pregnant, ma'am. And also,
So
if not in other case, so in some other case, if they are taking some other drugs which are teratogenic to the baby, which can also be modified during the preconceptional counseling period itself.
Okay, we can give a good preconceptional counseling, which is very important in all the cardiac cases before they plan for conception. Okay.
Yes, ma'am.
What is the WHO risk classification? Under which classification does it come?
No, this patient is an uncorrected atrial septal defect, which comes under high risk class of 2, ma'am.
1 or 2?
2, ma'am. Uncorrected atrial septal defect comes under 2.
Okay. So how frequently you want to call them for visit? In case you have diagnosed it early, how frequently you want to ask her to come for antenatal visit?
Depending upon the NIHA classification, ma'am. If the patient comes under class of 1 and 2, we can advise the patient to have monthly visit up to 28 weeks, ma'am. And after that, 28 to 36 weeks, we can call her for visits once and 2 weeks, ma'am. And after 36 weeks, weekly visit, ma'am. And we advise the patient to get admitted around term. If the patient comes under class of 3 and 4, as such in diagnosis, we have to admit the patient, hospitalize and manage them.
Okay.
So
how
what are
frequently
the...
you want to ask?
Ma'am?
Continue, please.
Nice.
Yeah.
Glucose
How
challenges was
frequently
done
you
at
want-
32 weeks. Ma'am?
Nothing. How frequently you will ask for a cardiology opinion for WHO2 classification?
It is in every trimester once we have to get cardiologist opinion.
Okay, fine.
Yes.
And
Glucose
how many
challenges was-
times you are going to do the 2D echo? How many times the 2D echo is necessary in your patient?
It comes under class 2, ma'am. Every trimester, the patient had done her first echo screening at the 3rd trimester itself, ma'am. So while admitting the patient, we have to do a screening echo again for this patient to rule out pulmonary hypertension or any shunt reversal in those patients, ma'am.
Dr. Suryakant, cardiologist from Durham Medical College.
Good evening, sir.
Good evening. I have a query for you. If you have diagnosed this patient as ASD in the 10th week itself, I mean 8th to 10th week itself.
Yes, sir. Yes, sir.
If you are diagnosed ASD in the 10th week itself, I mean
Yes,
first
sir.
trimester itself, you have diagnosed ASD.
Yes,
What
sir.
will be your advice to ask them to continue the pregnancy, or specifically you want to know anything from the cardiologist side?
Yes, sir. ASD is actually well tolerated during pregnancy, sir. And also our patient is in NIHA class 1, sir. We can ask the patient to continue pregnancy with regular follow-up and get a cardiologist opinion and plan if fast closure is needed, we can plan it around in the starting of second trimester around 14 to 18 weeks, sir.
Okay. Is it mandatory that you will advise for everyone device closure during pregnancy?
Depending upon the size of the
Usually-
lesion and the symptomatic of the patient, sir.
Yeah, it is not based on the size of the lesion. That's what I want to say. See, irrespective of whether it is a large AST or small AST, what you want to assess from the pregnancy point of view is you have to assess for pulmonary hypertension. In your case, you have mentioned no pulmonary hypertension. Then it is okay to continue with the pregnancy. If the patient is having pulmonary hypertension, that is important in case of atrial septal defect. Most of the time, atrial septal defect pregnancy will go uncomplicated till the end. But if the patient is having pulmonary hypertension, as you mentioned, you have to do for echo periodically. Every time screening echo is not going to help you much. But if the patient is having pulmonary hypertension, then it is very important whether it is getting worsened. Sometimes it may precipitate labor at the earliest time. So in your case, there is no pulmonary hypertension. So periodically going for echo, not much helpful, but we should monitor for pulmonary hypertension. It won't develop all of a sudden. For example, over 8 months each, it won't go for pulmonary hypertension all of a sudden. In that case, it is very important to seek some follow-up. Okay, proceed.
Yes, sir. Shall I continue, ma'am?
Yes,
Yes,
Navneeta.
continue.
Yes, ma'am. And there was no history of breathlessness, chest pain, or palpitation in the third trimester also, and the number of antenatal visits in the third trimester were 4. Past history, she was not a known case of diabetes mellitus or hypertension or bronchial asthma or epilepsy or tuberculosis. And there was no history of previous surgeries or blood transfusions or any other drug allergies. Family history, there is no history of heart disease among family members. Personal history, her bowel and bladder habits were normal and sleep and appetite were normal. There is no history of alcohol intake, smoking or substance abuse. Dietary issues, she consumes mixed diet. Summary, she's a 19-year-old teenage primary gravida, around 39 weeks of gestation, belonging to lower socioeconomic class, with no significant family history, who is a known case of atrial septal defect, with left to right shunt, with no pulmonary artery hypertension, with grade 1 bilateral pitting pill edema, had been admitted for safe confinement. On general examination, the patient is comfortable at rest, and she's not dyspneic or tachypneic at present. She's moderately built and nourished, with a height of 154 centimeter. Her pre-pregnancy weight was 46 kg, post-pregnancy weight was 58 kg, and the total weight gain in pregnancy was 12 kg, which is adequate, and her body mass index is 24.5 kg per meter squared. And she had no pallor or icterus or clubbing or cyanosis or generalized lymphadenopathy. Bilateral pitting pill edema of grade 1 was present. Breast, thyroid, spine, and guide weight normal. The oral dental hygiene was good, and jugular venous pressure was not elevated. Coming to the vitals, the temperature was 98 degrees Fahrenheit with a pulse rate of 90 per minute, which was regular in rhythm, normal volume and character. There was no radial delay, radiofemoral delay, and it is felt all peripheral plus equally felt, and there was no pulse deficit. The blood pressure was 110 per 70 millimeter of mercury measured in right upper limb in sitting posture, and the respiratory rate was 18 per minute. Systemic examination proper, cardiovascular system, inspection, the chest appears symmetrical, trachea is in midline, there is no suprasternal or supraclavicular pulsations, chest wall moves equally with respiration, no obvious chest deformity, apical impulse was not visualized, there was no precordial bulge or parasternal heave, and there are no scars, sinuses or dilated veins. And on palpation, the inspectory findings were confirmed. Apex peak felt at left to fourth intercostal space, 1 centimeter lateral to the midclavicular line, and there was no thrill or parasternal heave noted. Under auscultation in aortic area, S1 and S2 was here, and there was no murmur.
Navneeta, Dr.
Yes,
Navneeta,
yes,
during your inspection findings, you should not mention about the parasternal heave. Because parasternal heave should be mentioned under palpation.
Yes, ma'am. We'll correct it. Yes, ma'am.
Okay, right.
We'll correct it. In pulmonary area, S1 and S2 was present and there was no murmur. In tricuspid area, S1 and S2 was here and there were no murmur. In mitral area, and S1 and S2 was present and there were no murmurs. In respiratory system, bilateral air entry was equal. Normal vesicular breath sounds were heard and there were no added sounds. In central nervous system, there were no focal neurological deficit. In obstetric examination inspection, patient in supine position with semi-flexed knees, parts adequately exposed from zenisternum up to mid-thigh, abdomen longitudinal distended, stria gravidum and median icra were present, umbilicus in midline, flushed with surface, and there were no scars, sinuses or visible pulsations. There is no abdominal edema and hernial orifices were free. On palpation, after correcting the dextrorotated uterus, symphysis fundal height corresponds to 32 weeks with flanks full, and abdominal girth was 92 centimeter. On fundal grip, a broad, soft, non-independently ballotable fetal part, suggestive of breech occupying the fundus was seen, and in umbilical grip, right side, multiple small nodules were felt, suggestive of the fetal limbus, and on left side, smooth, curved, hard, uniform, resistant felt, suggestive of fetal spine. In the first pelvic grip, hard, round, independently ballotable fetal part, suggestive of fetal head, occupying the lower pole of uterus. In second pelvic grip, we confirm the findings of first pelvic grip, and head is not mobile and the hands diverge. And the Riker is clinically adequate with estimated fetal weight of 2.8 kg. Under auscultation, the fetal heart rate is 140 to 150 beats per minute, regularly heard in the rectus spine umbilical line. On pervaginal examination, the cervix was uneffaced, soft to posterior, os closed, head was at brim, pelvis gynecod, and there was no CPD, no show or draining PV, and the modified Bishop score was 2/13. Summary, Mrs. X, a 19 years old teenage prima gravida, who is a homemaker by occupation from Madurai, belonging to lower socioeconomic class, married since 1 year, with regular cycles, with gestational age of 39 weeks, with grade 1 bilateral pitting pill edema, who is a known case of atrial septal defect, belonging to functional class NIHA 1, who class 2, with single eye fetus in cephalic presentation, with good fetal heart rate, with no symptoms and signs of heart failure, in sinus rhythm, had been admitted for safe confinement.
So what is the indication of doing fetal 2D echo in your patient? Would you like to do a fetal 2D echo in your patient?
Yes, ma'am, definitely, ma'am. It is because every
What are the
congenital heart
indications? What are the indications to do fetal 2D echo?
Yes, ma'am. If the parents are having any congenital heart disease, there's a risk of about 2 to 15% incidence of congenital heart disease in the fetus, ma'am. To rule out that we should do, and also in GDM mothers, over DM mothers, to rule out any congenital heart disease, it should be done, ma'am.
Sir, do you want to opine anything? Any few points you would like to add, cardiology, sir?
I mean, now it is always considered to do a fetal echo also in every pregnancy, because apart from guidelines, this risk of congenital heart disease for ASD, it is only 2 to 5%. Usually we avoid, but even if we have to do echo, it's mandatory in case if the patient is having any complex cyanotic congenital heart disease. That itself considered contraindicated. Now, before first trimester itself, we can avoid that pregnancy. In those cases, the risk of congenital heart disease is higher, or else it's okay.
Thank you. Okay. So what are all the investigations that you are going to do, Dr. Navneeta?
Yes, ma'am. I would like to proceed with basic routine investigations like complete hemogram, liver function test, renal function test, serum electrolytes, and also electrocardiogram, ECG for this patient, along with echocardiogram, the cardiologist opinion, ma'am. Along with it, to look for the fetal assessment, expert ultrasound with amniotic fluid index with fetal Doppler to be done, ma'am.
Okay. What are the pregnancy symptoms that mimic heart disease, and how can you suspect heart disease when she's coming to you for the first time?
Breathlessness, undue tiredness or fatigue, those symptoms can mimic normal pregnancy, ma'am. If the patient is having progressive dyspnea with classical findings of orthopnea or paroxysmal nocturnal dyspnea, along with chest pain, palpitations, cough, nocturnal cough, along with hemoptysis, those are some of the symptoms of cardiac disease, ma'am.
Okay. Okay, so we have to avoid three diseases, right? So
yes,
that there won't be any heart failure. So what are those you said? One is preeclampsia,
yes,
anemia, infections, and
hyperthyroidism. Yes.
Thyrotoxicosis. So how do you manage your patient? She's 39 weeks. Why do you do a PV now? She's 39 weeks, right?
Yes, ma'am.
So is it necessary to do a PV now at 39 weeks when she's not in labor?
Not on to rule out CPD in primary gravida around 38 weeks, we can do cephalopelvic dysfunction assessment.
Routinely you're doing?
Yes, ma'am. 38 weeks for primary gravida.
Suhasini ma'am, Nagasudha ma'am, routinely are we doing PV at 38 weeks to assess the pelvic assessment, to do the pelvic assessment?
No, ma'am. Sometimes in labor only we can assess the cephalopelvic proportion.
CPD is assessed only in during labor.
Okay. Okay.
Okay. Now, how are you going to manage your patient? As she belongs to NIHA class 1 and WHO class 2. So how are you going to do the follow-up, evaluate her and manage her? You tell me that.
Yes, ma'am. She's having a gestation age of 39 weeks, ma'am. With the heart disease patient, we can wait for spontaneous onset of labor pain, ma'am. So if the fetal parameters and the AFI are adequate, I will wait for the patient to go into spontaneous onset of labor.
How do you manage first stage, second stage, third stage of labor?
The onset of labor,
anyway low risk.
Yes, ma'am. In the first stage of labor, as our patient is under NIHA class 1, ma'am, we can allow the patient to ambulate, ma'am. And also oral fluids can be taken adequately, ma'am. But other precautions like delivering the patient in a proper position, recommend position, and oxygen supply as and when needed should be sorted and made ready, ma'am. And vital monitoring should be done, like pulse rate, saturation, and respiratory rate should be done every 30 minutes, and blood pressure should be checked every hourly, with intermittent chest auscultation to road bilateral basal crux. Input-output monitoring should be done.
Is there a role for eye prophylaxis in this woman?
It is an uncorrected atrial septal defect which carries low risk of infective endocarditis, ma'am. So routinely prophylaxis is not needed, ma'am.
Okay. So
Adequate pain relief should be ensured in this patient, ma'am.
what is the pain relief you're going to give her? Or how
At the
are you
active
going
stage
to
of
relieve
labor,
her pain?
at the active stage of labor, we can go for epidural analgesia.
Okay.
And also, in first stage of labor, when the patient enters into second stage, it should be cut short by means of prophylactic forceps or vacuum delivery.
Can we use ventouse?
Yes, ma'am. Ventouse can also be used, ma'am.
Ventouse is better or forceps is better, and why?
In forceps delivery, the maternal efforts are not there, ma'am. Comparing to that, prophylactic forceps supplying is better than ventouse.
So usually ventouse is avoided. We have to do an outlet forceps. You have to tell
Yes,
as outlet forceps.
outlet forceps. Yes,
Then what else? Why do you
Yeah.
want to cut short the second stage of labor?
In order to decrease the maternal effort, ma'am. Because during uterine contraction, there is increased shift of blood from the uterus and placenta into the systemic circulation, ma'am, which in turn increases the cardiac load, ma'am. In the time, if the maternal efforts are more, the patient is more prone for growing into cardiac failure and pulmonary edema, ma'am. In order to avoid those strains on the heart, we have to cut short the second stage of labor.
Okay. Then
Stage of labor.
tell me, you have delivered the baby. How are you going to manage next?
Yes, ma'am. In the third stage of labor, the active management of third stage of labor should be employed, ma'am. And we should.
What is active management of third stage of labor?
Administration of injection oxytocin 10 units intravenously immediately after delivery of within 1 minute of delivery of the baby, ma'am. Delayed cord clamping. Controlled delivery of the placenta.
Controlled cord traction, yes.
Controlled cord traction, delayed cord clamping.
Okay. Then when do you observe? How do you observe the woman? How do you monitor in the fourth stage of labor? And when do you want to discharge her?
Yes, ma'am. The vital should be monitored every 5 minutes for the first 2 hours, ma'am. For the first half an hour, every 5 minutes, the vital should be monitored, ma'am. And then every 15 minutes for the first 2 hours, ma'am.
Okay.
And the patient should be kept in intensive care unit as she is more prone for going into pulmonary edema and cardiac failure for the first 48 hours after delivery, ma'am. And
when do you want to discharge her?
The hemodynamic parameters tends to come within normal range 14 days after delivery, ma'am. So probably after 2 weeks of delivery.
Okay. What is the family planning advice you're going to give her?
Temporary and permanent methods are available, ma'am. As she is a primary gravida, I tend to go for temporary methods, ma'am.
Like?
Intrauterine contraceptive device can be employed, ma'am, but it carries the risk of infection, ma'am. With adequate antibiotic prophylaxis, intrauterine contraceptive can be advised in those patients.
Then what else?
Barrier methods can be employed, but it has a higher failure rate, ma'am. Permanent methods of contraception in other women, we can counsel the couple first for vasectomy, ma'am. If they are not willing, we can advise tubectomy after 6 weeks of delivery.
Can she have a second child or no? Can your patient have
in our case, yes, ma'am. In our case, it's a primary gravida, ma'am. I tend to go for intrauterine contraceptive device.
And why do you want to go for permanent?
In other women, ma'am. In other women having
other women, yes, okay. So what are the other things? Can we give OC pills? Not now, exactly after 6 weeks.
Estrogen portion of oral contraceptive pills carries the risk of thrombosis, ma'am.
So when can you advise?
It can be advised after 6 to 12 weeks. 6 to 12
weeks. What can you advise now? You said
progesterone
can be given.
Injection.
Yes.
Progesterone multiples injection depot medroxyprogesterone can be given.
Antara. You have the program of Antara in your. Okay.
Yes, ma'am. We are following.
You're following that? Okay.
Yes, ma'am.
Okay. So again, you can. What is the spacing that should be there in this woman? How much spacing should be there? She's 19 years, right? That means it's a teenage pregnancy. The complications will be more.
Yes, ma'am.
As well, there is a chance of her going for a cesarean section as her pelvis is not properly developed. So during cesarean section, what are the precautions you're going to take and how are you going to prepare her for LSCS?
LSAS, if because of obstetric indication, if we are preparing the case for LSAS, we can go for regional anesthesia, ma'am.
What do you mean by regional anesthesia?
Which can be spinal and epidural, ma'am. Fluid
Which is
overload,
better?
depending upon the cardiac condition of the patient, ma'am. Epidural anesthesia is better.
Okay.
Yes, ma'am. And the fluid overload should be avoided in those patients, ma'am. Post-operative wound care and thromboembolic event should be avoided by giving yearly mobilization of the patient along with the pneumatic compression stockings or thromboprophylaxis can be started in those cases, ma'am.
Thromboprophylaxis.
Yes, ma'am.
You're starting for every patient?
High-risk women who are more prone for developing.
In this patient, would you like to give or no?
As a BMI comes under
prophylaxis.
Yes, ma'am.
Huh? You want to give or no? Only 1 point. If
No,
you
ma'am.
give, no or yes, because she is NIHA 1. That
Yes,
means
ma'am.
WHO class 2. So,
We can give.
okay, you are giving in your hospital?
Yes, ma'am.
Okay, what are you giving?
We are giving injection unfractionated heparin, 5,000 international units, depending upon the BMI of the patient.
Okay. She is, I think, she's not overweight, right?
Yes, ma'am.
Okay.
She's
For how
24.5
many
normal
days?
being.
For how many days?
Depending
Navneeta?
upon the high risk categories of the patient, ma'am, we for the plain cases we tend to give for 5 days now.
Okay. 5 days?
5 days is not.
Thinking
No, that's all. So either 7 or 10 days.
Doctor, will you give
Thromboprophylaxis is for 10 days or 7 days.
Yes, ma'am. Okay, ma'am.
What is the
She
drug
Are
you
you
are
giving
giving in your hospital? Cardiologist sir is saying something.
Is it thromboprophylaxis indicated in this case? You are planning for the patient underwent a normal delivery. Apart from LSU, normal delivery, is it indicated?
Sir.
The patient is going to stay for too long. That is more than 3 to 4 days. Prolonged hospital stay itself can provoke thromboembolic manifestations. So, yeah, we have a score, sir.
Just to make her
Based
answer.
upon.
Ma'am, it is not to criticize, just to make her answer. I want to make her answer. Okay. One more thing. Doctor, depending on the BMI you told, on what basis the BMI will alter your anticoagulant prophylaxis?
Sir.
Is it based on BMI?
Ma'am, body weight of the patient, sir.
Body weight of the patient. In what way it is going to help? For example, in what way it is going to help?
The patient is more than 90 kg. We tend to 1,500 international units are being given, sir. If it is less than that, normal dose of 5,000 is being employed.
Okay. Is it only hello? Hello. What if? So, am I audible?
Yes, sir. Now
Sir.
you are audible.
Breaking, sir. Yeah, you are audible.
Okay. What if it is, for example, this patient develops DVT? You should have it in mind. If the risk is different from routine patients developing DVT with a patient with atrial septal defect developing a DVT.
Yes, sir. Definitely it is there, sir. This ASD patients can develop DVT and there is a term called paradoxical embolism where the venous emboli can enter into systemic circulation and cause pulmonary embolism risk.
This kind of patients are very important to have a sudden arrest because it not only goes to pulmonary embolism. Pulmonary embolism sometimes may survive, but if it goes to the systemic circulation, they may have a sudden cardiac arrest even. So in this case, it is very important. If we miss the DVT or something, we may end up in a definite complication. Okay.
Okay. Thank you. Thank you, Dr. Navneeta. You have well presented. Good. That's an excellent job you have done. If I was your examiner, yes, I would have given a good mark to you. Yes, Radhika, can we go for the next case?
Yes, ma'am. Sure.
Thank you. Thank you, Navneeta.
Thank you, Aruna, ma'am. Very encouraging you are. Yes, ma'am.
Thank you, Aruna, madam. Your questions are so sharp and very informative, madam. Our PGs will learn a lot from you, madam.
Thank you. Thank you so
At
much.
a periphery
Thank you for
college
the
like
opportunity.
yes, madam.
Thank
You
you for
people
the
are like
opportunity,
them, madam.
Anjalakshi ma'am, Sampath ma'am, and Vidya Prabhakar. Thank you so much for this opportunity. Thank you, Dr. Radhika.
Thank you, ma'am. Thank you, ma'am, for your valuable time you allotted for us. Thank you, ma'am.
Yes, madam.
So next case, Dr. Surya.
Yes. Good evening, ma'am. Good evening to respected all, ma'am. I'm Surya, final year postgraduate from Department of OBG, Government Sivanga Medical College and Hospital. And Mrs. Podhambanna, 13 years old, residing at Natarasagote village. She is a housewife, studied up to 12th standard, socioeconomical status as class 4 according to modified Kupasamy classification. Her upstudy score is graded to para 1 level, booked an immunized case. And her LMP is 21/11/24, ED is 28/7/25, last child birth is 2 years, their gestational age is 34 weeks. The patient came to OPD with the complaints of breathlessness on and off for the past 1 week on doing her day-to-day activity. He is able to perceive fetal movements well. And patient was apparently healthy before 1 week, after which developed complaints of breathlessness on and off, insidious in onset, gradually progressive in nature. She is having breathlessness while doing her day-to-day activities. Patient also complaints of palpitations present, no complaints of orthopnea, paroxysmal nocturnal dyspnea, no complaints of chest pain, syncope, no history of reduced urine output, cough with expectoration, hemoptysis.
Surya.
Yes, ma'am.
What is paroxysmal nocturnal dyspnea?
Patient, ma'am, good evening, ma'am. Patient developed breathlessness while patient in lying posture, ma'am. The patient, if the patient is in lying posture.
No, I want a better answer. Because this is very, very important symptom that she's going to have. So what is paroxysmal nocturnal dyspnea?
The patient, while sleeping, the patient developed a breathlessness. This breathlessness awake the patient from the sleep to get
exactly.
well saturation, good saturation.
Yes, exactly.
In order to relieve from breathlessness.
What is orthopnea?
Patient developed breathlessness once lying posture, ma'am.
Okay. Continue. So no what complaints. What is a positive history in this patient?
The patient having breathlessness and palpitation, ma'am.
Palpitation. Okay, right.
Yes. No history of childhood fever associated with the joint pain swelling. No history of recurrent episodes of sore throat. And past history, not a known case of diabetes mellitus, hypertension, bronchial asthma, TB, epilepsy, and thyroid disorder. Patient's known case of rheumatoid heart disease for the past 2 years and diagnosed in her first pregnancy accidentally and started on tablet penicillin 250 mg/d taking till now and mild MS with MRs present. No history of any surgery, no history of blood transfusion, no history of allergy to any drug. And menstrual history, she had a regular 3/30 cycle not associated with the clots and dysmenorrhea. Married since 3 years, non-consanguineous marriage. History of intrauterine contraceptive insertion after first pregnancy and removed 1 year back. And family history, no history of heart disease among family members and first degree relatives. No history of congenital anomalies at pinning in family. No history of medical disorder in family. And personal history, mixed diet, normal sleep pattern, normal bowel and bladder habit, no substance abuse. Her obstetric history, first pregnancy, spontaneous conception, booked and immunized, delivered an alive term female baby of birth weight 2.5 kg by prophylactic outward force of delivery at Government Sivanga Medical College and Hospital. Baby was 2 years old and alive and healthy. No history of symptoms suggestive of cardiac disease during pregnancy. Echo was done at 34 weeks and diagnosed as RHT. Her antepartum, intrapartum, postpartum period was uneventful. And present pregnancy is a spontaneous conception, booked and immunized, confirmed by UPD at 45 days. In her first trimester, he had no history of excessive vomiting, fever with rash, abdominal pain, bleeding, spotting PB, no history of radiation exposure, teratogenic drug intake. Dating scan was done and dates found to be corresponding. NT scan was done and told to be normal. Folic acid taken regularly. ECG and echo was done at private hospital and diagnosed as mild MS with MR. And advised to continue tablet penicillin 250 mg BD. And second trimester, quickening felt at 16 weeks of gestation, taking iron and folic calcium tablet regularly. Second dose of TT was received. Anomaly scan done was 22 weeks and told to be normal. Fetal echo was not done. GCT was done, told to be normal. And third trimester is able to perceive fetal movements well. No complaints of bleeding or draining per vaginum. Growth scan done at 34 weeks. No complaints of headache, clearing of vision, epigastric pain, reduced urine output. And examinations is comfortable at rest, not dyspneic, not tachypneic at present.
Surya, 1 minute. You have presented a case and we know that there is a change in the cardiovascular system during pregnancy.
Yes, ma'am.
Okay. When is the patient prone to develop failure? in her pregnancy? What are the stages where she is more prone to develop failure?
The patient in pregnancy, the hemodynamic changes are started to change at early weeks, ma'am. Its peak is 28 to 30 weeks, ma'am. So patient have more chance of developing cardiac failure at 28 to 30 weeks and during labor and postpartum period, ma'am.
That's it,
So
only
around 16 weeks, is there going to be increased cardiac output around 16 weeks?
Yes, ma'am.
So now you tell me, what are the risk points to develop heart failure in this pregnant woman we have to suspect? One is?
Patient have more chance of developing cardiac failure because increased cardiac output at 16 weeks. There is a placental sinus opening. The more chance of more chance of reduced peripheral vascular resistance, ma'am.
Okay. Then the second.
Then at 20 to 30 weeks, because of hemodilution, ma'am, there is a more volume expansion. The cardiac output is increased, plasma volume is increased, so patient have more chance of developing cardiac failure, ma'am.
Okay. Third.
During labor and postpartum period, there is an auto transfusion of more amount of blood entering into the systemic circulation, ma'am.
Okay.
And,
after that.
Because of straining of the pain, there is a sympathetic activation during labor pain, ma'am. So there is cardiac overload, cardiac workload is increased, ma'am. So patient having more chance of developing cardiac failure.
So then, there is. Okay. Then.
Okay, then
one more high risk period to develop during labor. Yes, you came till labor. Yes, then later.
In postpartum period also, there is more chance because in postpartum period, because of auto transfusion, more blood entering into the systemic circulation, the patient having more chance of developing cardiac failure within 6 hours, 6 to 12 hours of postpartum period.
5 hours is more common. Okay. Okay. So what do you prevent, or which are the risk factors to develop heart disease? I mean heart failure in your patient. The same question is asked to Navneeta also. You also answer.
If the patient associated with the hypertension, anemia, it should be corrected vigorously, ma'am. The patient having anemia is aggravate the cardiac failure, ma'am. Patient having more chance of developing cardiac failure, ma'am. If the patient developed a fever or any infection, asymptomatic bacteriuria should be treated, ma'am.
Only two things, huh? Apart from hypertension, anemia, or infection.
Hypertension, anemia, infection, and diabetes.
Okay, then hyperthyroidism also can precipitate failure.
Okay, please continue with your case.
Examination pays comfortable address, not distinct, not tachypneic at present, moderately built and nourished. Her pre-pregnant BMI is 25 and present BMI is 27.3. No pallor, icterus, cyanosis, clubbing, generalist lymphadenopathy, pedal edema, press thyroid spine appears normal. Her vitals temperature was normal, pulse rate 100 per minute, regular in rhythm, normal in volume, no radiofemoral, radial delay. All peripheral pulses well, no pulse deficit, and BP is 130-70 millimeter of mercury. Respiratory rate is 16 per minute. There is no elevated jugular venous pressure.
How do you check for JVP?
The patient should be in 45.
Check for JVP? Yes.
Yes, sir. 45 degree of reclining position. It should be measured by 2 scale or 3 scale method. By 3 scale method, 1 scale placed at the upper limit of venous column. 1 scale is placed at the angle of 2 is. The distance between these 2 scales are measured, ma'am. If there is less than 3 is normal, we can add 5 centimeter to measure the right atrial pressure, ma'am.
Okay, you have checked in your patient?
Yes, ma'am. It's less than 3 centimeter, ma'am. No elevated JVP.
Right.
Yes, ma'am.
Please continue.
Proceed. Yes, from cardiovascular system inspection, chest appears symmetrical, trachea and midline, chest wall moves equally with the respiration, no obvious chest wall deformity, apical impulse not visualized, no suprasternal, supraclavicular pulsation, no elevated JVP, no precordial pulse, no sinus cords dilated veins. And inspectory findings are confirmed. Tracheal in mid position, apical impulse felt at the left fourth intercostal space, 1 centimeter lateral to the midclavicular line. No palpable thrill, parasternal heave is noted. And auscultation, mitral area S1 is loud, a rough rumbling, low pitch grade 3 mid diastolic diastolic murmur pursued in patient in left lateral position with the birth held at expiration with no radiation. And other areas as soon as I heard no murmur, respiratory system bilateral air entry equal, no added sound, CNS examination was normal. And abdominal examination, splatter emptied, patient in supine position with the knees are semi-flexed, exposed from cephisternum to mid-thigh. On inspection, abdomen longitudinally enlarged, stria gravitarum, linea nigra C. Umbilicus is midline, clustered with surface, no scar, sinus dilated veins, no abdominal wall edema seen, hernial orifice is free. Patient symphysis fundal height is 34 cm, abdominal girth is 89 cm, fundal grip, broad, soft, non-independently palatable, fetal parts felt, possibly breached. Umbilical grip, multiple small nodule felt on right side, possibly lymphoids, and smooth, curved, uniform rested felt on left side, possibly spine, and first pelvic grip, hard, round, independently palatable, fetal part felt, probably head. Lycus appears clinically adequate, estimated fetal weight is 2 kg, and auscultation, fetal heart rate is 140 to 145 per minute, which was regular in rhythm, heard in left spino-umbilical line. And summary, 31 years old, Mrs. Podhumbadna, EDD on 28/11/25 with a 34 weeks of gestation.
Surya, tell me one thing. Suppose she's come to you for the first time during her first trimester. She's a second gravida. Previously, there was no heart disease. It was not diagnosed, right?
Yes, ma'am.
So she had a full-term normal delivery. Now, again, after her pregnancy test is positive, she's come to you. So
Yes.
how do you suspect and how do you diagnose MS or heart disease in this woman?
Patient having breathless in first trimester, na?
Everyone will have, most of the pregnant women will have breathlessness and
Yes,
they
ma'am.
can have a tachycardia, right? So
Yes, ma'am. Yes,
how can you suspect and how can you diagnose it?
Physiological breathlessness is not associated with the palpitation. There is no orthopnea, nocturnal cough, paroxysmal nocturnal dyspnea, ma'am.
Okay.
If the it's not associated with the edema, ma'am. If not associated with the pedal edema.
So you're going to take a thorough history. Yes, agree.
Yes.
Second, next.
General examination, ma'am. Examination for her vitals and auscultation of cardiovascular system for presence
Yes.
of murmur.
So auscultation of the heart is very, very important that we are missing nowadays. In Telangana also, as Dr. Radhika said, there are more deaths because of missed heart disease. Okay, that's why our government said that every pregnant woman should undergo ECG and 2D echo at the end of the first trimester, at the end of the first trimester. So we are doing regularly. Okay, continue.
34 years old Mrs. Podhumbadna, EDD on 28/11/25 with 34 weeks of gestation with a single live intrauterine gestation of pregnancy with a cephalic presentation with a clinically adequate liquor, known case of rheumatic heart disease. For the past 2 years on tablet penicillin 250 mg BD with the complaints of breathlessness on day-to-day activities belonging to NIGA class 2 with the previous prophylactic outless forceps delivery with mid-diastolic murmur in mitral area. A case of acquired heart disease, rheumatic mitral stenosis with the mitral regurgitation in sinus rhythm without signs of cardiac failure for further management.
How do you assess the severity of the mitral stenosis?
Measuring valve diameter, ma'am. If my diameter is less than 1 centimeter meter square, it's severe mitral stenosis, ma'am. 1 to 1.5 centimeter moderate, and 1.5 to 2.5 centimeter square, it's mild mitral stenosis.
Suppose it's a severe mitral stenosis. She's come to you in the first trimester, around 8 weeks, yes, with positive symptoms. So what do you do?
If mitral stenosis is the cardiac failure,
severe mitral stenosis, yes. When do you call it severe mitral stenosis?
Less than 1 centimeter.
So she's come to you in the first trimester. So what do you do about her?
Severe mitral stenosis in first trimester, we can plan for surgical management. If patient associated with intractable pulmonary edema, pulmonary hypertension, atrial fibrillation, which medically stabilize, patients should stabilize the patients, and we plan for mitral valve commissurotomy in second trimester.
Second trimester.
Yeah.
Dr. Surya Kant, sir, I think you should intervene.
Yeah. Doctor,
yes, sir.
The mitral stenosis is defined by area, not the valve diameter. One correction in that. Okay.
Yes.
It is not mitral valve diameter, it's mitral valve area in centimeter square. Number one. If it is a severe mitral, okay, let me ask you a different question. What are the cardiac conditions in which pregnancy is contraindicated. For example, they are coming you for the preconception counseling.
Yes, sir.
What are the cardiac diseases in which you can say it is contraindicated? Name
Yes,
some
sir.
condition.
Sir, Marfan syndrome with aortic root dilatation of more than 45 mm, sir. Eschenberger syndrome, that's primary pulmonary artery hypertension. The patient with severe mitral stenosis with symptomatic severe aortic regurgitation, sir.
Severe mitral stenosis. Okay, that you mean to say severe mitral stenosis in the preconception period itself is a contraindication. Am I right?
Yes, sir. Yes, sir.
Okay. Then one more valve lesion which is contraindicated. Which lesion? Pregnancy is contraindicated.
Aortic stenosis, severe aortic stenosis, and severe
Very good.
coarctation of aorta, sir.
Yes, these three conditions, this we are commonly seeing, but we are going through many normal patients are undergoing deliveries, everything. But severe mitral stenosis as such comes under the contraindication for pregnancy.
Yes.
If it is a severe mitral regurgitation alone, will you
Yes,
say
sir.
pregnancy is contraindicated?
No, sir. It comes under WHO class 1, sir. So we can allow her to continue her pregnancy, sir.
Why, doctor? Why mitral stenosis comes under this mitral regurgitation comes there?
Sir, in mitral stenosis, there's more chance of developing hemodynamic changes. The cardiac workload increase.
Okay, let me explain you that. See, generally, regurgitant lesions are better tolerated during pregnancy.
Regurgitation tolerated.
Lesions are better tolerated. Why? Because when there is reduced peripheral vascular resistance, this blood, regurgitated blood, will go into the circulation. It will not precipitate a failure. Because in pregnancy, there will be decrease in peripheral vascular resistance. So the amount of functional regurgitation reduces. That is the difference between a stenotic and a regurgitant lesion. So pregnancy tolerates regurgitation because of low peripheral vascular resistance. One point. Yeah. So that is why regurgitant lesions are better tolerated. My question is, okay, patient has severe mitral stenosis, you have allowed her for a pregnancy, I mean, 10 weeks are there. You want to correct when?
Sir, if patient having pulmonary edema, pulmonary hypertension, atrial fibrillation, we can correct at any trimester, sir. We can plan for surgery, sir.
Any trimester?
No.
Even at term, we can plan.
Sir, is that true?
No, ma'am. No, definitely no.
No,
See,
you
doctor,
have to correct yourself, Surya.
Second trimester.
Second trimester. The answer is
planned at second
Is
trimester.
safe only during second trimester.
Second trimester. Why, doctor? Why second trimester? If you know the reason, you won't. Then that too, you don't say a surgery. See, for example, the surgery is different. Correcting it with commissurotomy is different. For example, a pregnant patient, you want to undergo a open heart surgery with general anesthesia during second trimester. I mean, you want to say, you told me surgery.
Closed mitral valve balloon valvuloplasty.
Yes, it is balloon mitral commissurotomy. It is something different from a cardiac surgery. I don't want an open heart surgery for a pregnant patient, that too in a second trimester with general anesthesia, which may make the fetus also suffer. That is why we are allowing only commissurotomy, that too in the second trimester is an ideal thing to be corrected. Is there any indication for surgery? You said surgery. You mean commissurotomy, but you said surgery. That's okay. But you want to do any surgery during second trimester? Now, what kind of surgeries you want to do?
Sir,
for example, for instance,
valvuloplasty.
Doctor, valvuloplasty and these things are peripheral. I mean, that is not open heart surgery. Your answer should be like, I don't want any open heart surgery with a general anesthesia for a pregnant patient. That is, yes, it is a closed mitral commissurotomy, balloon mitral. Your safer answer will be balloon mitral valvuloplasty. The safer answer is yes.
So this is minimally invasive. Yes.
Yes.
One more question for you in the so it is a. Can you take an X-ray for your pregnant patient?
It's not informative, sir. Now we can take with the abdominal shield.
This will not be approved. For example, you are referring a patient for CT pulmonary angiogram. Is it okay to take a CT pulmonary angiogram for a pregnant patient? You are taking, right? I mean.
Sir, it's only condition if suspecting pulmonary embolism, we can do CT pulmonary angiogram, sir. Otherwise, not needed.
Okay. See, the general teaching is we should not expose any pregnant patient to X-ray because of teratogenic effects. But taking a CT up to With the lead shield is okay. Lead shield over the abdomen. Okay. Why I ask this question is balloon mitral commissurotomy we can do only in the presence of radiation. The examiner may ask you, it is a radiation exposed procedure. Can you do that? Abdina, your answer should be two things. One, we are doing it in the second trimester. Number two, the answer should be like, we can place a lead shield over the abdomen and then proceed with the procedure because only the heart is exposed during the procedure. In that way, you can escape.
And the radiation is negligible. It doesn't cause any side effects or adverse effects on the patient.
Okay. You refer and tell me how much X-ray you can take. I mean to say, how much chest X-ray is permissible for a pregnant patient. You refer and tell me. The exposure is minimal. Actually, we are more frightened about the radiation exposure, but there are guidelines. In pregnant patients, how many X-rays can be allowed? We are going to take only for indications, but there is a guideline. How much X-rays we can take? You refer and tell me.
Chest X-ray, it's exposure to 0.1 rad, sir. Less than 15 rads.
How many chest X-rays? The question is right. We don't measure how many rads. How many chest X-rays we can take? That is a easy answer, la. Instead of remembering this rats, grades, so there is no use in memorizing this rats and grades. So we can learn in such a way that how many X-rays can be taken, how many CTs can be taken. Okay.
Yes.
Proceed.
So apart from your valvular lesion, what about NIHA 3 and 4? Whether they can, if they come in the preconception period, what will be your advice? Whether they can conceive or conception is contraindicated?
NIHA 3 and 4, we can terminate the pregnancy, ma'am. It's contraindicated.
Preconceptionally, if they come, what will be your advice?
You tell us about the preconceptional care, preconceptional counseling in your woman, in your patient.
NIHA 3 and 4 is contraindication for pregnancy. Counsel her to.
Is it possible to surgically correct it or no?
Possible to surgically correct.
Then why do you want to avoid pregnancy in your woman?
Ma'am, we should evaluate the patient and advise to depending on the type of lesion, advise her to correct the lesion.
No, your patient is it is moderate or mild MS, right? So if it is severe, belonging to 3 or 4, so she's come to you preconceptionally without conception. She wants your advice. What are you going to plan for her?
Echo should be done. We should, if the patient preconceptually comes now, we can plan for clovital valvuloplasty. Ma'am, advise her to do valvuloplasty, then advise to conceive.
In your case, no, doctor. In your case, it is a case of mild MS. She can continue with the pregnancy. In your case, it is mild mitral stenosis.
Yes, sir.
So, in case
I'm asking if it is severe.
Yes, severe.
Severe na advise her to do valvuloplasty, ma'am.
Okay.
Cardiologist opinion, valvuloplasty.
Okay. So do you want to keep your patient admitted or you want to discharge her and ask her to come again? How many, actually, according to WHO, how many antenatal checkups should be there? Minimum and maximum. Now, not only in your patient, in every antenatal woman, how many checkups according to WHO guidelines?
NIHA 1 and 2, we should add.
No, not in your patient. Any antenatal woman.
Ma'am, WHO 8 to 6.
8 to 14. Yes, 8 to 14. Why they have increased from 4 to 8? Surya?
To evaluate the patients by increasing visit, we can.
To reduce the morbidity and mortality both in mother and the fetus. So you said you have immunized your this woman, but you never told me you have used TT, TD or TDAP. What do you use in your hospital and which is better?
TT. Tetanus diphtheria.
You're using TT or TD in your hospital?
TD.
TD. Okay. Right. So how do you tell me how to continue and how do you manage your patient? You want to keep her admitted or discharge her and again call her back?
I will admit the patient. I am doing routine investigations, ma'am. and ECG, echocardiography, and watch for signs of progression of symptoms and signs of cardiac failure watching.
Suppose you have diagnosed her in the first trimester, you want to keep her till term, till she delivers?
Depending upon the progression of the symptoms, ma'am. If patient change from NIGA 3.2 to 3.4, na, we can terminate the pregnancy, ma'am.
Terminate.
So,
Surya?
At second trimester, if she comes at NIHA 3 and 4, what is the plan?
monitoring, a careful monitoring and plan for valvuloplasty, ma'am. Close to mitral valve.
Okay, what is the plan of keeping her in admission or discharging her? Ma'am is asking,
Yes.
when will you keep her in admission?
Your
Admit
patient,
her,
I'm only
keep her in
talking about
admission.
your patient.
Keep
See,
her in
Surya.
admission, ma'am.
Continuously. She's mild MS, right? Neha, 1 or 2?
If patient improving now, I will discharge the patient, ma'am. In my case, ma'am, if patient improving now, we can discharge the patient after 2 weeks, ma'am. After 36 weeks, advise her to weekly review, ma'am.
No, I don't
If
agree
patient
because 32,
worsening now,
you said, you yourself said 32, 34 weeks is the risk period for heart failure. 14 to 16 weeks, it's also a high risk period. So yes, you have discharged after 20 weeks.
2 weeks.
Then you're going to readmit her or no?
If patient developing symptoms worsening now, will readmit, ma'am. Otherwise,
Nagasudha
weekly
ma'am, do you agree for that?
No, madam, no, madam. If she is NIHA 3 and 4, we will admit her. Otherwise, we have to admit at 32 weeks since 32 to 34 weeks since she is prone to develop failure at that stage.
Yes. Surya, you should answer that. You have given us the risk periods, right?
yes.
When she develops heart failure. Okay. Now you tell me how you're going to manage your patient. Now she is how many weeks? 34 weeks.
34 weeks.
Yeah. She is with you now. What are you going to do?
I'm doing basic investigation, ECG, echocardiography, ma'am. From cardiologist opinion.
Okay.
Then watching for signs of cardiac failure symptoms, pulmonary hypertension, pulmonary edema symptoms, ma'am. Patient develop now, will treat accordingly, ma'am.
Okay.
Okay, how are you going to treat if she is in failure? Suppose she has gone in for failure.
From admission, patient nasal O2, diuretics, ma'am. We can beta blocker, digoxin,
Diuretic
anti-failure drugs.
dose of diuretic.
Furosemide.
First of all, you have to confirm whether she is in failure or not.
So
And
how do you
what is the
confirm? How do you confirm that she is in failure?
Clinically, by signs of cardiac failure, ma'am. If cases MS more favor for developing right heart failure, ma'am. So presence of persistent pulmonary edema, hepatomegaly, rise to JVP. If the patient having these symptoms now, is diagnosed as cardiac failure. Will diagnose as cardiac failure.
What about basal crepes?
Basal crepes. The patient having basal crepes now is having pulmonary edema.
That's more important, right?
Yes.
So how are you going to treat her?
IC care admission, nasal O2.
How much?
First position. What is the position you have to place?
Propped up position.
Yeah.
Propped up. Okay. Then?
Nasal O2, 6 to 10 liter. Very breathable mask, ma'am.
Okay. 6 to 10 liters. That's a wide range, right? Okay. Okay, tell me then.
Vitals monitoring by connected to multi-parameter monitors, head BP, pulse rate, saturation, and intermittent auscultation of chest, input-output monitoring.
What is the dose of Lasix that you are going to give? Furosemide.
40 mg. I will start.
Surya sir, are you available?
Yes, he is there.
Sir,
Yeah.
please add on your input, sir, regarding management of failure.
Regarding management of failure, the first thing is identification of the failure is important. One
Yes,
thing,
sir.
if the patient is having symptoms of the patient, see, if the patient is tachypneic, you are admitting the patient normally, all of a sudden, if the respiratory rate goes high, tachycardia, it is important because mitral stenosis patient cannot tolerate much tachycardia because in tachycardia there won't be much output. So you should tell some basics like tachypnea, tachycardia, and then like Krebs. So usually in pregnant patient you won't be able to make up this hepatomegaly or anything else. So the acute signs will be like tachypnea, tachycardia, and basal crepitation. So as you have already said, proper position is important. What basically sometimes go wrong is we will be giving fluids for the patient sometimes. Restriction of fluids is important, either in the form of IV fluids or oral fluids. You have to restrict the fluid intake for dehydration status. Then the next thing is Lasix. Lasix you can give in split doses rather than giving 40 mg and then wait. Usual practical approach will be like give 20 mg and then wait for some time and then you can give fresh doses. That will be fine. At that time, symptomatically, for example, if the patient heart rate is too high, we have to treat the heart rate also because if the heart rate is too high, the output will be very low. That will be also so rate controlling drugs. What rate controlling drugs? Preferably beta blocker you can give. You can give like metoprolol. So that will control the rate indirectly, helps the patient to settle down faster.
And nowadays we are not giving digoxin in these
Digoxin.
patients.
Ma'am?
Roll of
Digoxin,
digoxin.
digoxin is nowadays we are not giving, sir.
Not using them. We are not using because see the metoprolol itself most of the time will control the rate, ma'am. So most of the time we are not just using digoxin practically unless a patient is in a atrial fibrillation, chronic patient with atrial fibrillation. In that cases we are using, but mostly we are not using it. Practical purpose we are not using, ma'am.
Okay, right. Thank you. And Surya, now what are the complications that you can expect with MS?
Mitral stenosis, the patient develop atrial fibrillation, ma'am. If patient develop the atrial fibrillation, they are more prone for thromboembolic episode, ma'am.
Okay.
The patient develop pulmonary embolism, failure, pulmonary edema.
Okay. Suppose you got 2D echo done and there is a clot inside the atria. Okay. Now, how are you going to tackle this case? I know we are going to take an opinion of a cardiologist, but how does he treat it?
By starting heparin, ma'am, since he is in 34 weeks, we can start anticoagulation, ma'am, heparin.
What type of heparin?
Ma'am, unfractionated heparin, ma'am. Unfractionated heparin, 5,000 units IV.
Unfractionated heparin. Okay.
You
How
can
much
also-
dose?
IV,
What is the
QID,
dose?
or TDS, or BD?
PD 5,000 units.
5,000 units BD, right?
Yes, ma'am.
Whether it's a treatment for thrombus or it is a treatment for thromboprophylaxis. Thromboprophylaxis only you are going to give a BD dose.
BD dose.
Subcutaneous BD.
TDS.
Therapeutic, you have to go for IV QID and you have to monitor with PTINR. What will be the charge of PTINR?
Ma'am, 2.5 to 3, ma'am. INR for unfractionated heparin, 2.5. 2 times.
Fractionated heparin you are
INR
going to monitor
2.5 to 3, PTINR 2 times the control, ma'am.
Dr. IF, heparin you are going to monitor with PTNR. Are you sure?
No, sir, it's not for monitoring that. We are planning for therapeutic range of INR.
Ma'am?
Usually, heparin won't.
APTT. Ma'am, by heparin we can monitor with the APTT, sir. Prothrombin type.
Yeah, heparin you have to monitor with APT.
Yes, sir.
Madam asks you PTNR to plan for any delivery you are planning. For example, you are doing for section, then you have to maintain INR and consult your anticoagulants. For that, INR monitoring is important. Can we give oral anticoagulants?
Yes, sir. We can use oral anticoagulants, sir. After 34 weeks. Sir, if the patient before 36 weeks, we can use oral anticoagulants, sir. Nearing term, nearing delivery, we can convert her to unfractionated.
No. Now she's having a clot in the atria. I told you. So can you use warfarin? I mean, the oral anticoagulants.
It's bridging of because oral anticoagulants takes time to maintain the PT-INR, ma'am. So both heparin and warfarin we can start, ma'am. After 4 to 5 days with INR of 2.5 to 3, we can start heparin.
So you will bridge with heparin and warfarin, and you will switch over to warfarin once you reach the target levels.
Yes.
How much days will warfarin take to act? Why we have to go for bridging?
Warfarin takes 3 to 5 days, ma'am, for reaching a therapeutic value, ma'am, therapeutic level.
Why we are giving heparin in that time? Is it because warfarin will take 3 to 5 days time, or warfarin will do some other thing?
It's pro-anticoagulants, so pre-heparinization is needed for warfarin.
Yeah, it inhibits protein C and S also, which may cause a procoagulant tendency. At that time, we need to bridge with heparin. When will you stop?
Heparin we can start at 36 weeks, sir. The warfarin we can start at stop at 36 weeks, sir. At 36 weeks we can convert to the patient to heparin, sir.
If the patient is already on acetrom in the first trimester itself,
Yes, sir.
for example, say 5 weeks,
Yes, sir.
5 to 6 weeks,
Yes, sir.
will you continue acetrom?
So it's dependent upon dose, sir. If the patient taking less than 5 milligram of warfarin, we can allow her to take heparin, sir. If it has less than 5 milligram dose, their fetal teratogenic effect is less than 3%, sir. So it's equivalent to heparin teratogenic effect. So we can allow her, sir.
Very good. We can allow.
We can allow. And heparin doesn't cross the placenta. Surya,
Yes, ma'am.
you have to
Yes,
remember that.
Yes, sir. Yes, ma'am.
So postpartum, how long do you want to continue?
After 2 weeks, we can continue thromboprophylaxis.
2 weeks, that
No,
is 14
this
days. Will that be sufficient?
No. No, already she has got a thrombus. Prophylaxis only is for 10 days to 10 days. She has a thrombus, CVT, DVT. How many days you have to continue the anticoagulant?
So prophylactic and therapeutic. Here we are giving the therapeutic dose. So how long do you want to continue?
6 weeks. Up to 6 weeks.
Okay. Right, up to 6 weeks.
Yes.
Okay. Now you tell me, suppose she's asking for contraception. She doesn't want to get a tubectomy done now, even though she's second gravida. So what are you going to do? No, you tell me about the intrapartum management. One is propped up position, oxygen. Yes. Then
Vitals monitoring. With
multi-para monitor.
Yes, ma'am. Vitals monitoring and input-output monitoring.
Fluid
Pain control with
restriction.
the analysis, ma'am.
Fluid restriction.
Yes, ma'am. Fluid restriction less than 75 ml per hour.
And pain management.
By epidural anesthesia. In second stage of labor, in order to cut the second stage, we can use forceps or vacuum, ma'am.
No. You tell one, forceps or vacuum?
Delivery, ma'am. Forceps we can use.
Forceps. Why forceps is better than vacuum? I don't agree with vacuum.
Ma'am, in forceps delivery, there is no need for maternal effort, ma'am. So we can use forceps. Okay, then AMTSL you are going to do. So now you tell me about the risk period of postpartum period. Within
high risk, yeah.
In postpartum period, within 6 to 12 hours of post-delivery, ma'am.
Okay.
After 6 to 12 hours, there is auto transfusion. More chance of developing cardiac failure. Patient should be in close monitoring up to 6 to 12 hours, ma'am. So how are you going to manage PPH if she's having a PPH, atonic PPH? How are you going to manage the same woman? PPH. Yes, ma'am. By oxytocin, misoprostol we can use, ma'am. Avoid ergometrin, ma'am. It's because potent vasoconstrictor and increased maternal hypertension. We can avoid ergometrin, ma'am. Methergin should be avoided. Or oxytocin, misoprostol. Okay. Carboprost we can use. You can use carboprost? Yes, ma'am. We can use.
Are you using Corboprost?
Carbitocin is available in. Carbitocin, Carboprost we can use. PGE2 can use with Casu.
PGF2 alpha, I'm talking about that.
Yes, but PGF2 alpha we can use according to.
Okay. So you can use misoprostol, right?
Yes, ma'am.
Suppose it's not under control? It's still not controlled?
We can go for in our college. We are having SR cannula, ma'am. If we don't need postpartum hemorrhage, we can use SR cannula, ma'am.
What is the infection rate with SR cannula? Can we use SR cannula in this patient of yours?
Patient with good antibiotic prophylaxis, antibiotic coverage, we can use, ma'am, in order to prevent.
Aseptic precaution. Not only a good antibiotic coverage, it should be used as an aseptic precaution, autoclaved.
Yes.
Okay. Suppose she's asking you for the contraception. So how are you going to counsel her? What is the advice you're going to give her?
I advised the permanent method of contraception, ma'am.
Okay.
After 6 weeks,
because she's got already 2 children. Okay.
Yes, so permanent method advised tubal sterilization after 6 weeks. Or if the patient not willing for tubal sterilization, we can use progesterone only pills, DMPA injection, or advised husband vasectomy, ma'am.
So, okay, what is the discharge summary that you're going to give her? What is your advice in the discharge summary? When are you going to discharge her?
14 weeks, after 2 weeks of 2 weeks of delivery.
So what is the advice
days.
you're going to give her? Because she's a case of MS, mild MS, right? Oh, so, okay, what is your advice?
Is to continue penicillin prophylaxis and regular follow-up after 6 weeks and 4 to 6 months. Patient should after 6 months we should do re-echo.
Okay, right. So do you have any questions, Dr. Nagasudha?
Yes, ma'am.
Yes.
Yeah, in the case of failure, you have treated the failure. What about the obstetric management? Are we going to allow her for vaginal delivery, or are we going to allow her to continue the pregnancy?
We can allow her for vaginal delivery with the effective analgesic management. We can allow vaginal delivery.
In a patient who has gone in for failure. Failure, will you allow him?
Intractable cardiac failure is an indication for elective cesarean section.
What?
In cardiac failure, patient if having intractable cardiac failure, we can plan for elective cesarean sections.
So elective means?
Elective? You mean to say elective?
Cesarean section. C-section.
No. You have to stabilize.
Why cesarean section?
If patient developed a cardiac failure, if not managed, if patient not controlled with medical management, we can do cesarean section.
Then it is an elective cesarean, Ada.
So
what are the indications of cesarean section? Cardiac indications for cesarean section.
Yes, ma'am. If
that's a nice question.
Marfan syndrome of high-degree dilatation more than 45 centimeter. If patient and vitamin K and on warfarin with preterm labor. If the patient on warfarin, it needs imminent delivery. Primary pulmonary hypertension, Eisenmenger syndrome. Severe aortic stenosis.
Hypertension, yeah. Pulmonary hypertension, then?
Aortic stenosis. Severe coarctation of aorta.
Yeah, coarctation of aorta.
Not all coarctation of aorta, but if there is a root dilatation.
Yes, more than 45 TMM of dilatation.
Aneurysms?
Aortic aneurysm. With aneurysm size, is more than 50 mm, we can go for cesarean section.
Okay.
Surya sir, do you want to add anything, sir? Cardiac indications for cesarean section.
Yes, cardiac indication. As such, to practically say, these are all the conditions, but these are all the causes which you have mentioned as a contraindication for pregnancy. Am I right? To say Eisenmenger syndrome or syndrome with root dilatation.
Yes, sir.
If they came to the last trimester, then it becomes an indication for cesarean section. As such, apart from this, there is no definite cardiac indication. As I said, these are all the alternate reasons. For example, you said Marfan syndrome with root dilatation. These are Eisenmenger syndrome. These are all the conditions in which pregnancy is contraindicated. That then becomes the indication for surgery. As such, there is.
Yes. Yes, sir.
But failure as such is not an indication. Even the intractable failure, you can treat with Lasix. Lasix, yes, clinically it is possible with oxygen and Lasix. You need not do a cesarean section. It will burst the condition. Okay, Surya?
Yes, yes, ma'am. Yes.
Okay.
Wonderful, ma'am.
Thank you, Radhika.
Yes, ma'am. Those days we used to have lots of.
Thank you so much.
Yes, ma'am.
Thank you, ma'am.
Nakasuta ma'am. Thank you.
Thank you.
Thank you, Aruna madam. Thank you so much for your valuable inputs and guiding our PGs.
Thank you for the opportunity.
Thank you, ma'am. Thank you, Aruna Suman ma'am.
Thank you.
Thank you so much, Suhasini ma'am, Nagasudha ma'am. We've given very good training and the PGs have done very well. Thank you so much.
Thank you.
And thank you, Suryakant sir, for your valuable inputs. And thank you, TNFOG organizer, Dr. Sampath ma'am and Dr. Vidya Prabhakar ma'am. And above all, our thank you, Sagiti, for the wonderful support, IT support. Thank you all. We'll meet again once more. And our heartfelt invitation for you, ma'am, Suman ma'am, Aruna Suman ma'am, and for the FOGSI conference in July.
Yes, sure, definitely.
Yes, ma'am.
Thank you. Thank you so much for the opportunity.
You, please register, ma'am. Surya.
Sure.
Sorry, Dr. Nagasudha ma'am. And the postgraduates also, please attend the conference.
Thank you.
Thanks a lot.
Thank you. Thank you, Dr. Suhasini ma'am.
Thank you, ma'am.
Suhasini ma'am, yes. She's our favorite internal. Thank you.
Oh.
Thank you so much.